From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello, and welcome to our listeners around the world. I'm Dr. Ishani Ganguli, an associate editor at JAMA Internal Medicine and your guest host for a special episode of our Author Interviews podcast. Today, I'm talking to authors of 3 studies that caught our attention at the 2025 Society for General Internal Medicine annual meeting. You'll hear about a trial evaluating interventions to improve blood pressure control by helping patients access food, and a study about transatlantic differences in how clinicians care for patients with dementia at the end of life. But let's start with Dr. Lisa Rotenstein, a primary care physician and assistant professor of medicine at the University of California, San Francisco. Welcome, Dr. Rotenstein.
Thank you for having me.
Glad to have you. So your study looks at how commonly American doctors are reporting incomplete team staffing and how this relates to burnout and work intentions. I'd love for you to share with us, how did you come to this research question?
We know that the COVID pandemic was associated with stress and work overload, yes, among physicians, but also among all role types. Nurses, other clinical staff who are integral to our clinics and our hospitals who may not have clinical roles. And we know that teams are critical for how we deliver healthcare and then also for the experiences of physicians. And so we wanted to understand, now that we are some years out from the peak of the COVID pandemic, what is the staffing of healthcare teams like nationwide, and how is this affecting the experiences of our physicians?
So tell me a bit about the survey you analyzed. Who and what does it represent?
Our study was based on data from the AMA's organizational biopsy. This is a survey that is focused on organizations with more than 100 physicians, and it helps organizations measure their workforce's well-being. It has a core set of questions that all organizations ask, and then a set of customized questions that organizations can choose from. And this survey has several questions related to staffing and work intentions. And specifically in this analysis, we focused on physicians who answered a question about team staffing in 2023. And this question, which we'll talk about in more depth shortly, I'm sure, asks what % of the time do you work with less than your fully staffed team? So this is with fewer than your standard number of support staff, whether due to vacations or illnesses or workforce shortages. And I'll just emphasize that it lets respondents define for themselves what constitutes a fully staffed team.
Got it. So what did you find?
We found that 48% of respondents worked with an incompletely staffed team more than 25% of the time. You might ask how we picked that cutoff. We did look at the distribution across our respondents, but those of us who practice clinically and work in clinical teams felt like that was a proportion of the time where working with an incompletely staffed team would really affect day-to-day clinical functioning. And we were surprised to find that nearly half of physicians worked with an incompletely staffed team that much of the time. And the prevalence did vary by specialty. So, for example, we found that nearly 45% of primary care physicians worked with an incompletely staffed team more than 25% of the time. 62% of other specialists, which includes, for example, radiologists, anesthesia, pathologists, worked with an incompletely staffed team that often.
That's pretty incredible. So how did this relate to other aspects of physician well-being and intentions with staying in the workforce, for example?
So let me talk about what we know about well-being and work intentions among this population first. We found that 48% of physicians in the study met the criteria for burnout. 26%, so more than a quarter, indicated an intent to reduce their clinical hours in the next 12 months, and 15.4% indicated that they were likely or definitely going to leave their current clinical role in the next 24 months. And then we found that working with an incompletely staffed team more than a quarter of the time was significantly associated with these outcomes. So physicians who worked with an incompletely staffed team more than 25% of the time had more than 2 times greater odds of burnout, 1.5 times the odds of intent to reduce clinical hours, and 1.65 times the odds of intent to leave. We can intuitively sense that working with an incompletely staffed team is difficult. Those of us who practice feel that day to day. And now we have concrete data that working with an incompletely staffed team is associated with the health of our workforce. It's associated with greater odds of burnout, of intending to leave the role. And that ultimately has implications for our patients and the care we deliver.
So what can policymakers or health system leaders do about these results?
Thank you for asking that question. That's really important, and that's really why we did this study. I think it's important to pay attention to the experiences of the entire healthcare team in order to ensure that we are delivering great care and are sustaining our physicians in the workforce as well. And so what does that mean? We found in a study during the COVID pandemic that there was work overload among all members of the healthcare team. And so it's critical for health system leaders to be thinking about what we are asking of those on our clinical teams to ensure that they feel like they have a place in our organization and we are watching out for them as well. And some of this also comes down to the way that we pay for teams. For example, in primary care, we know that team-based care is associated with good outcomes for our patients and greater satisfaction for physicians. The way we often pay for primary care through fee-for-service billing doesn't necessarily sustain strong teams. And so it's a real opportunity for us to think creatively about how we pay for healthcare in a way that sustains multiple members of the team in addition to physicians.
Absolutely. Well, it was such a pleasure to talk to you, Dr. Rotenstein. Congrats on the study, and I look forward to seeing you around the SGIM meeting.
Thank you.
Later, we'll be talking about end-of-life care on both sides of the Atlantic. In the meantime, I'm here with Dr. Seth Berkowitz. Dr. Seth Berkowitz is a primary care physician and associate professor of medicine at the University of North Carolina, Chapel Hill. He'll present results of a pragmatic randomized comparative effectiveness trial on interventions to improve blood pressure control among adults with food insecurity and hypertension. Welcome, Dr. Berkowitz.
Yeah, thanks so much for having me. I appreciate it.
Yeah, so tell me about how you decided to tackle the problem of hypertension using food access.
There are a couple things that came together for this. One, we know that food insecurity, uncertain access to the food needed for an active, healthy life is a major problem, highly prevalent in the US and unfortunately only growing in prevalence. We also know that diet-related illness is a really big problem. And of those, hypertension is probably the most common diet-related illness and is responsible for a lot of cardiovascular morbidity and mortality. And so it seemed like a natural fit to use an intervention that addresses food insecurity and makes it easier for people to follow a healthy diet as a way to try to improve blood pressure control.
So how did you think through the various interventions that you offered patients in the study?
Yeah, so this is an area where, big picture, it all sounds very plausible, right? Healthy food, better blood pressure control, better health outcomes and those kind of things. But often the devil is kind of in the details. And when you start thinking about, well, how do you actually do this? Then, a lot of questions keep coming up. And so there could be variations in the way you offer healthy food. Should people go out and buy healthy food for themselves, or should you deliver it to them in some way? There can be variations in how much extra support you offer. Should there be lifestyle intervention and healthy eating advice that goes along with it? Or will people just need to be able to acquire the food, but otherwise know what to do with it? There are questions about how long you do this for. Should we do it for a shorter or longer period of time? Longer may be better, but it also may be more expensive. And in fact, all of these different questions have a component of the expense to them, where the way you answer which variation to use might have cost implications too. And so there just turned out to be a lot of details that we thought it was worth trying to work through and get some evidence on in order to hopefully help build the most effective and efficient intervention.
So that makes a ton of sense. How do you then take those ideas and those comparisons that you're interested in and operationalize that? So talk me through how you designed the study, where did the study take place?
Yeah, so because there's so many different questions and because it seemed like sort of a pressing thing to get answers on, we tried to kill a number of different birds with this study. And at some point, I think that made us tear our hair out a little bit as we're designing it. It's a factorial trial with 3 different dimensions. And so you get 2 by 2 by 2, which is 8 possible combinations of what people can get into, which I think seems a little nuts when you start talking about it. But I think all the different aspects make sense. And we sort of had an opportunity to study them together. And so we thought about the design along 3 different dimensions or axes. So one was the type of food resources provided. We compared a food subsidy where people were provided with a dollar amount on on a card that could be used to purchase WIC eligible items. So fruits and vegetables with no added salt, sugar, or fats, whether fresh or frozen or canned, but as long as it met those criteria. But people could go out to a local grocery store chain and redeem that within those parameters as they chose. So that was sort of one dimension. So along that same dimension, the other aspect was having food be delivered. So we did a delivery every 2 weeks to people's home of sort of a fresh produce box. So we worked with local farmers and a local food hub that actually supplied these foods and delivered them to people about every 2 weeks or so. And for that dimension, the food subsidy was a little bit less expensive and the food box delivery was a little bit more expensive because you're, storing fresh produce and delivering it and that kind of thing. We also had a dimension of providing lifestyle support or not. And so there, providing lifestyle support is more expensive. And the lifestyle program was one that had been previously shown to be effective in prior trials and emphasizes sort of a Mediterranean diet pattern, but using foods that are common and preferred in the American South, which is where the study was set in North Carolina. And then finally, we looked at different durations of intervention, so either 6 months or 12 months. We recruited people from healthcare systems in central North Carolina. These were all people who reported food insecurity, who had a diagnosis of hypertension and had a blood pressure in the last year, suggesting that there was some room for improvement in their blood pressure. So either a systolic blood pressure greater than 130 or a diastolic blood pressure greater than 90. Guidelines suggest that either of those parameters should be lower than that. And so suggested that there may be some issues there. So we enrolled participants from essentially a healthcare setting, and then people were randomly allocated to one of these 8 different intervention arms.
Gotcha. I want to make clear to our listeners that no birds were harmed in the making of this podcast or in the study. I'm sure you agree, Dr. Berkowitz.
Yep.
So you designed this really thoughtful study looking at these different parameters of more intensive, less intensive. What did you find?
So ultimately, we found that along the axis of the type of food resources provided, the food subsidy actually led to a larger reduction in blood pressure than the food box. So about 3 millimeters of mercury systolic and about 2 millimeters of mercury diastolic difference between the two arms. This is sort of a comparative effectiveness study. So we're not comparing one intervention to no intervention. We're comparing 2 sort of active food insecurity interventions. And we found that the food subsidy arm was a little bit better in that sense. And that I think is important because the food subsidy, again, was the less expensive arm. And so not only did you get better blood pressure control, but you kind of did it for lower cost. Along the other axes, we really didn't see much difference. So adding the lifestyle support did not make much difference. The caveat to that is that participation with the sessions was relatively low. We did a lot of things to make it as easy as possible. The study was conducted, a large part of it during the COVID public health emergency. So we had telephone and video-based sessions. They're all one-on-one. Tried to schedule it. Could be off hours or weekends or other things like that. But even with that, it was difficult for people to engage. And so hard to say whether it's that the lifestyle intervention itself wasn't effective or just the engagement with it. Sort of watch out the effect there. And then finally, we didn't see much difference with the duration of intervention. So the 12-month intervention didn't lead to larger blood pressure drops than the 6-month intervention.
Got it. So it sounds like the subsidy and the shorter intervention duration is the way to go. Is that your takeaway as well?
I think on average, that's definitely the case. As you know, with randomized trials, what you're getting is sort of an overall impact. So that doesn't mean that there's not any individual person who might not have done better with, a different dimension or something like that. But on average, yes, I think the food subsidy looks like it was more effective and there was no benefit to a longer duration on average. Again, there may be individuals who might benefit from a longer one, but.
Got it. So knowing what you know from these results and what you and your team have learned, what would you want to tell health systems and communities who want to implement an effective strategy to reduce hypertension in this population for themselves?
Yeah, one really important takeaway is that food insecurity is a target that is probably worth going after. There are lots of different ways that you can try to improve blood pressure, obviously medication adherence and affordability, physical activity intervention, all these things may work, but I think this is fairly solid evidence that food insecurity is a target that you can go after. I think it also is interesting and something to consider, that it's not just a question of the amount of resources input into the program, right? So people with food insecurity overall will tend to have lower income than people who are food secure and things like that. And so one hypothesis might be the more resources you put into it, the better, because you're making up there. But I think this kind of suggests that the way you structure the intervention may matter to some extent. And so it's not just a question of the amount of resources put in. That's not to say that that doesn't matter. I think, of course, it does, but there's a little bit of nuance there too. And then the other thing I'll just say, and you can almost view this as walking back a little bit from the results, but I think it is consistent with the results, but just an important distinction when you go from the research space to the implementation space is, even though on average we did not see differences in duration or differences with the lifestyle intervention, that doesn't mean that for any individual person that may not make sense. And the nice thing about the implementation is, if you were to structure it such that there is, say, an optional lifestyle intervention or an initial 6 months followed by a check-in and recertification where someone might be renewed for an additional 6-month period or something like that, you would, in some ways, I think, sort of get the benefit of both worlds in terms of you're only paying for the intervention as it's delivered, right? And so if it turns out that people just don't wind up using the lifestyle component that much, that's fine. You don't have to staff up to support everyone being able to get that. You can have a much smaller staff to deliver it and that kind of thing. Similarly, if there are a lot of people who have an episode of food insecurity, and so by 6 months their situation has changed and they don't need further assistance, then great, you can wrap up the program then. But if you do find people who are in a little more persistent state of food insecurity or something like that, you might extend the intervention for a smaller number of people. And so I think building some flexibility into the implementation, even while understanding the averages and saying, yeah, maybe we start off by just offering a food subsidy for 6 months duration or something like that to everyone, makes sense, but there is room for a little bit of nuance there too.
Yeah, personalized medicine, if you will.
Yeah, exactly. I mean, people have used terms like precision population health or those kind of things.
Yep.
And I think you could use some of the evidence from this study to help build out programs like that when you're actually implementing them.
Well, Dr. Berkowitz, it's been a pleasure to talk to you. Thanks so much for sharing this great study with us. I look forward to seeing you around SGEM.
Yeah, absolutely. Always great to catch up.
And finally, we have Dr. Elizabeth Dzeng, a hospitalist physician, sociologist, and associate professor of medicine at the University of California, San Francisco. Dr. Dzeng will present the results of her qualitative study titled Differences in Clinical Practice Norms Around Offering and Administering High-Intensity Life-Sustaining Treatments for People Living with Advanced Dementia Near the End of Life in the U.S. and the U.K. For the study, Dr. Dzeng and her team interviewed hospital-based clinicians from the U.K. and the U.S. across disciplines, specialties, and stages of training. So, Dr. Dzeng, how did you decide to compare the U.S. and the United Kingdom on their approaches to end-of-life care, and why in this population in particular?
Yeah, so first of all, thank you so much for inviting me. So my research focuses on understanding how institutional cultures, ethics, and policies influences decision-making and clinical practice patterns in serious illness care, particularly around high-intensity end-of-life care and potentially non-beneficial life-sustaining treatments. So I've always been very interested in examining comparatively how different cultures and countries that have lower intensity of care compared to the US, why do they have lower intensity of care? Now, of course, national healthcare financing and national culture plays a role, but there's also modifiable systemic and institutional factors that might influence that.
And so why the UK and the US in particular? Was there a contrast there you were interested in?
Yeah, so I think the UK is a really interesting country to explore. They do have similarities to the US in terms of, we're both English-speaking countries. We have similar-ish cultures and religions and that sort of thing, and a similar history. However, there's a national health system in the UK, the National Health Service, and there's a very different way that people think about the ethics around care. So there's a focus on a just distribution of healthcare. There's a focus on what's in the best interest of people. And so I thought it was a really interesting comparison to make. The UK also has a much lower intensity of end-of-life care, particularly among older adults and in intensive care. And as I said earlier, it's due to many different factors, but what I'm particularly interested in is what are the modifiable institutional factors that might influence these differences in intensity of care.
And how did you decide to focus on this population, so patients at end of life, specifically with advanced dementia?
Yeah, so, end-of-life care is a very challenging ethical issue. those of us who are clinicians, we've definitely encountered in our career some of these ethical challenges. And so I wanted to choose a population where there's a lot of evidence that shows that particular interventions such as intensive care admission, mechanical ventilation, CRRT, these sort of interventions may not be beneficial for people with advanced dementia. And there is clear evidence that the harms can outweigh the benefits of these intensive treatments in this population. So I felt like exploring this issue with this population seemed like a really good way to start exploring some of these ethical challenges.
Makes a ton of sense. So tell us what you found.
Yeah. So as an American physician practicing in the US, there were some really interesting findings that came through this research. The first theme that was really interesting was that the point of contention around what are the ethical challenges around providing life-sustaining treatments or treatments near the end of life in older adults with advanced dementia was very different in the UK as compared to the US. So as an American physician, and this was a comparative study where I was using the same interview guide between the US and the UK, I would ask US physicians, what are your challenges around providing treatments such as mechanical ventilation and CPR to older adults with advanced dementia? And people would talk about that particular issue. When I talked to UK physicians and asked that same question, they would say, oh, well, that's not something that I would ever encounter. We almost never do these life-sustaining treatments such as CPR and mechanical ventilation on older adults with advanced dementia. However, the provision of antibiotics and fluids, that's the sort of point of contention that we have in the ethics around providing treatments for older adults with advanced dementia. Their feeling was that those were treatments that may not necessarily help patients and may harm patients. And so that was a much more contentious point of intervention in the UK. The second theme that was of great interest, and again, let me talk about the questions that I was interested in. I would ask them, well, what are your informal criteria for admitting somebody to the intensive care units, an older adult with advanced dementia? And in the US, they would say, oh, well, it would be unethical for me not to admit a patient to the ICU unless we hear otherwise from the patient. So the default and the ethical imperative was to admit to the ICU. In contrast, in the UK, people would say it would be completely unethical to admit an older adult with advanced dementia, given that it would be so harmful and the evidence shows that it's not beneficial to them. So why would we harm them in that way? So that was a really striking theme to me as well. And then the third theme, which kind of, I think, gives a little bit of insight into how people are able to do this in practice, is that UK respondents talked about how they could rely on guideline-oriented practices based on institutional and national criteria to limit that non-beneficial life-sustaining treatment. And so they could depend on these practice guidelines, these policies to limit that care when they felt it would be non-beneficial.
That's fascinating. So I'm hearing you say that US clinicians have a very different place they draw the line of what's appropriate or not compared to UK clinicians. And it sounds like the UK clinicians felt a lot more supported by their institutions, their systems to guide that more appropriate use of care.
Exactly, yeah.
So interesting. So wonder if you could share a quote that particularly touched you or inspired you in this work.
Yeah, so there were so many quotes. I did 130 interviews as part of this study, and there were so many quotes from United States physicians that really described the moral distress that came with feeling like they provided care that wasn't beneficial to patients. So one particular quote that illustrates this is, I feel like I lose a piece of my humanity when I feel like I'm forced to do CPR on an 85-year-old. And unfortunately, this is not a rare quote. This was something that just came up again and again in a lot of my interviews.
And to contrast that to the UK clinicians expressing distress at providing antibiotics and fluids for these patients, it's really striking.
Mm-hmm. Yeah, exactly.
So taking these results, how can this be translated into meaningful reduction of this low value care for these patients, care that actually causes harm? And specifically, what do you want policymakers to take away, clinicians, system leaders?
What my research really tries to understand and to highlight is the importance of these systemic factors, these institutional cultural norms, these institutional policies. So what I call institutional structures, policies, practices, allocation of resources, all the things that are at a systemic level that influences what an individual physician can do. Any individual doctor can try to limit care that they feel like wouldn't be beneficial to patients. But if they're within a culture that encourages high intensity care and that has these institutional cultures, ethics, structures that just encourage this default of high intensity care that we see a lot in the United States, that's not going to be very possible for those individual physicians. And so when we're thinking about interventions or policy changes that we can try to implement at an institutional level to mitigate potentially non-beneficial life-sustaining treatments, we really need to think about what we can do on a systemic level to support physicians. So this could be policy changes. This could be having more supportive ethics committees or having other supportive structures, supportive leadership, more funding for palliative care services. All these things work in concert to help promote norms that encourage lower intensity end-of-life care. And so thinking about the US and the UK, looking at the UK, there's, of course, things that we probably can't change in the US to be more like the UK system because we are inherently a different culture and nation. However, there are things that they have in the UK, such as the guidelines, as I mentioned earlier, and different ethical norms that are influenced by their institutional culture that we might want to think about how can we encourage these institutional structures. And I think institutional leaders can really intentionally design institutional structures to foster this culture of more appropriate end-of-life care that ensures that we provide care that's beneficial to patients.
Yeah. And it's so interesting. Culture is such a hard thing to change, as you've articulated. I wonder if there's a role for changing the framing, using your study and the results to think about how we frame those decisions for US clinicians and really highlighting the harms and the way that UK clinicians have thought about this as a way of changing the conversation around some of these decisions.
Yeah, that's a really important point. So yeah, I think that's a really interesting question. I think that we can think about the ways that we frame and prioritize different ethical principles. So you can either think about providing patient autonomy. We can think about providing care that's in the best interest of the patient. We can think about the just allocation of scarce healthcare resources. And one thing that I've noticed between the US and the UK is that there's a different prioritization of patient autonomy versus, for example, patient best interest. And that's actually reflected in policies in the UK. The Mental Capacity Act, for example, really focuses on a best interest framework. And so again, I think that the UK is a very different country from the US. And so we might not necessarily be able to fully focus on a best interest framework. However, can we balance things a little bit more? Can we think about ethical principles more holistically to think about not just patient autonomy, but balancing patient autonomy with like what's in the best interest of the patient and how we're thinking about allocation of resources in hospitals?
Makes a ton of sense. So what can a clinician working with patients at the end of life take away from these results?
One of the main conclusions of my study is that it's really important to think about the system and the culture within which your hospital operates. And so I talked about how institutional leaders and people who are doing research and interventions on serious illness care can think about designing policies and practices to facilitate ethical care. However, for the individual physician, I think that one of the take-homes is that you're not alone. Like, there is a lot of moral distress around this issue. This is something that we all grapple with as clinicians, and that there are just certain things that we are able to influence in our practice of medicine, but also recognizing the tremendous impact of our hospital's culture, our country's way of doing things, our ethical systems that our hospital cultures encourage in all of us. And so just recognizing that that is an important part of our practice and that we are working together with our colleagues to try to provide the best care possible and that we're all trying to do our best, but we all may be sucked into this default of high intensity care or these other cultures that occur in our hospital, and that we can just all try to work together to like provide the best care possible for patients.
Thank you so much, Dr. Dzeng. It was a pleasure to talk to you. I look forward to seeing you at the meeting.
Thank you so much.
I'm Dr. Ishani Ganguli, and I've been speaking with Drs. Berkowitz, Rotenstein, and Dzeng about the fascinating work they're presenting at the 2025 SGIM annual meeting. The meeting is always such a great chance to reconnect with friends and colleagues, learn from new research, and spark ideas for our own clinical practice and policy efforts. You can find a link to the related article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.